Hi, everyone. Welcome to another episode of the HemOnc Pulse. I'm your host, Dr. Rahul Banerjee from the Hutch Cancer Center in Seattle, Washington. It's my privilege today to be joined by Dr. Uma Borate, who's a clinical associate professor at Ohio State University Comprehensive Cancer Center, as well as the James Cancer Hospital. And she is a clinical research director of the acute leukemia program. And we'll be talking about myeloid malignancies and how to detect them and prevent them. Dr. Borate, Uma, if I may, pleasure to have you here.
Thank you, Rahul. Pleasure to be here.
Absolutely. I am a humble myeloma doctor, so I will say you are definitely the expert here for myeloid malignancies. Maybe can you start maybe at a high level, just walk us through early detection of myeloid malignancies? What even does that mean? Is that CCUS and CHIP, or is that kind of detecting MDS and AML before it happens? Is that more than that, less than that? And why do we need to do it? Maybe we can start there. Big picture, why does this topic matter? Every story has a pulse. Let's check the vital signs of what's happening right now.
I'll start by saying, as the humble myeloma doctor, I feel like the myeloma field has really shown us the way in kind of both the challenges and the opportunities for early detection. And I think maybe drawing an analogy to the myeloma story, which you probably will be able to teach me a couple of things and even correct me if I'm wrong, is, we've known about MGUS for very, very long time, multiple decades. When I was a fellow, MGUS was like, you have it, you'll be fine, come back and see us once a year. But from what I can see in the last few years, there's been an explosion of stratifying MGUS to where you have your smoldering multiple myeloma. Now there's been multiple trials looking at early intervention. And then you have this debate as to who are the people that really are ripe for early intervention, where you are balancing the toxicities of all of the therapies with the potential harm, and or are you really impacting the natural history of the disease? What if you waited till they develop overt myeloma? So I would say, to draw a parallel to myeloid malignancies, we are in the very, very infancy of those discussions because we don't have. So I would say the myeloid equivalent of MGUS is probably CHIP, where we find a clone, right? You have normal blood counts. You don't really have organ dysfunction. Your bone marrow is working fine. Your blood counts are normal. But for some reason, and we can talk about why this gets detected in people in the first place, if your counts are normal, you find a clone that's detected that is carrying a set of myeloid malignancy predisposing mutations. So the most common being what we call DTA, meaning DNMT3A, TET TET2, and then A stands for ASXL1. So you're carrying these mutations, your counts are fine, and that's your definition of CHIP. The agreed on limit of detection for CHIP is a 2% variant allele frequency on standard next generation sequencing. But then next step, and I would say probably maybe equivalent to your smoldering myeloma, is where now you're seeing some involvement of, we don't have the true kind of organ dysfunction that you see in myeloma, right, with bony involvement and all of that, but we see bone marrow involvement, and now the patients are getting cytopenic. This is typically when they come to medical attention, they now have a cytopenia, the PCP sees it, somebody sees it, they go to work it up and they can't find a cause. They end up in our office, we do a bone marrow biopsy, but they don't really have overt myeloid malignancy like MDS or AML, but they definitely have a fair-sized clone. And we believe, again, this is important, we believe that it's the clone that's contributing to their cytopenias and not anything else. And that's the CCUS, or clonal cytopenias of uncertain significance. So that's sort of our equivalent of early detection time points and diagnoses, where there's a lot of debate and discussion on what does that mean? Is early intervention even necessary? Is it a possibility? And so on and so forth. So I'll stop there and see where that takes us.
Yeah, absolutely. Well, I guess maybe the first thing I'll ask, because I learned about CHIP as a medical student, younger than you are, right? And I learned it more in the cardiovascular section of our courses about how it's a risk factor for inflammation and all this other stuff. And because that's one difference between our worlds. And for MGUS, that I'm worried about really is progression to myeloma. There's some loose evidence that maybe MGUS osteoporosis link, really shaky. I don't think that's real. Here, CCUS or CHIP can cause other problems as well. So maybe just briefly, what are you worried about if someone comes into your clinic with CHIP or let's say CCUS? What are all the things that could go wrong to them that are on your head? And does inflammation factor into that or no? Now, let's follow the flow. How does everything connect?
Yeah, I think that's a very important question. And I think you're right. The CHIP story really took off after there was I would say serendipitous finding in the cardiovascular world where they found, and different people obviously working on the same things all came to similar conclusions, that when you intervene to decrease risk of cardiovascular disease, the most prominent being this trial conducted that was a CANTOS trial where they intervened in a very large setting with an IL-1 beta antibody to decrease inflammation. And these were high-risk cardiovascular patients. They'd had previous cardiovascular events, and the endpoint was a very cardiovascular endpoint, right? History, risk of developing an NSTEMI or a stroke. And they found that the patients that had the most benefit with this anti-inflammatory strategy was actually patients that turned out to have CHIP. And the biggest, most well-detected CHIP was TET2. And then the story emerged that there's a very nice biological explanation for why when you have a TET2 mutation, the TET2 mutant cells really kind of exacerbate this inflammasome where they encourage macrophages and monocytes to come to the site of inflammation, secrete IL-1 beta and other inflammatory cytokines, and then they sort of have this positive feedback loop. And so that really cemented the role of CHIP in cardiovascular disease. And I think that's a very now well-established risk factor. What I don't know is, has it entered the mainstream? Like, do you go to your cardiologist with, high cholesterol and they say, hey, let's look for CHIP and let's, do something. Yeah, no. I mean, you can give people a statin, but there's a lot of cool studies coming out to see how you can actually modify cardiovascular risk from CHIP, which I think is a whole nother topic.
Yeah.
And then there's the second aspect of this where CHIP really is not life-threatening. It doesn't increase your risk necessarily of a myeloid malignancy, unlike, like you said, with MGUS and myeloma. But then once you start developing CCUS, which is a more sort of advanced stage, the clones are bigger. Now you're talking about the risk of MDS and AML not being trivial. It's still not a huge risk, but it is definitely a risk that has to be factored in. But to your other question about what else can these pesky mutations cause? And I always think of Disney movies. You have young children, I have young children. Yep. And when you think of Disney movies, you have the villain, you have the hero, and then you've got like the most entertaining sidekick. Like there's always a sidekick to the villain that's causing trouble, contributing to the chaos. I think of CHIP mutations as the villainous sidekicks for all the real badness that happens. And one of the most compelling articles, and I think, again, there's been many different people that have worked on this, but there's been this growing story that says if you have CHIP mutations, your outcomes with solid tumors. And I'd be curious to see, and I think there's evidence with myeloma as well, but really with solid tumors, the presence of CHIP mutations decrease your overall survival, your recurrence-free survival, and in general affect a lot of treatment-related outcomes just by being present. And nobody kind of understood this. In the beginning, people were like, obviously, if you have TP53 or PPM1D and you give people radiation and chemo, you're growing the clone and then they'll get secondary MDS or AML. Or if you give them Revlimid, for example, for the rest of their lives, you're really encouraging this clone to grow into MDS. And that's like a well-described story in myeloma. But now there was a recent, and by recent, I mean like 2 days ago, publication in the NEJM where there's multiple groups that came together from the UK and from the US that looked at, a huge sample size of solid tumors. And this was from MSK, and this was also from a non-small cell lung cancer cohort from the UK, where they showed that the real issue seems to be when these tumor infiltrating cells contain CHIP mutations, and TET2 being the biggest villainous sidekick, that something happens in the tumor microenvironment that does not allow therapies to work well. Maybe it's immunotherapies, maybe it's chemotherapies.
That's brilliant.
I know. Yeah. And it just impacts, survival for these unfortunate patients who are dealing with a completely different cancer, right? They're not talking about heme malignancies. So I would, at risk of making CHIP very simple, it's really the villainous sidekick. It messes with your cardiovascular risk factors to increase your risk of cardiovascular disease. It infiltrates the tumor microenvironment and really prevents a robust immune response in solid tumors. And then obviously, if you have enough high-level CHIP clones, you have an increased risk of MDS or AML just by itself. And this is, I think, from my perspective as a clinician, that's why I have to worry about context. And again, going back to the myeloma story, just because that's your area of expertise, we get a lot of patients on myeloma therapies because your patients do so well. They're living for 10, 15, 20 years. And they, unless you have studies, which I know you guys are working on to prove otherwise, most of them get Revlimid for literally ever. And we do see there's consequences to that, right? Because they may have had a CHIP clone when myeloma was discovered, when therapy was started, but now you're putting selective pressure on this clone because continuous Revlimid therapy. And maybe the answer is something else. Maybe the answer is for your standard risk myelomas, you guys will soon have evidence to say maybe you don't need Revlimid forever. Maybe DARA is the right way. I don't know. But the point being, the CHIP is this underlying troublemaker, and you got to be careful at how you're inciting that troublemaker and helping it become a real problem.
Agreed. I love this. So for those listening in, I looked it up, Dr. Borate, correct me if I'm wrong, said by the new journal, Medicine paper, Tumor-Infiltrating Clonal Hematopoiesis by Oriol Pisha and colleagues, published April 23rd. Pivoting now, just so we don't talk forever about this, it's fascinating. I've actually already learned a lot. Now we've moved from kind of the big picture Disney analogies here to now the nuts and bolts practical. So someone walks into your clinic, let's say, so now the general community hematologist, let's say, diagnoses CCUS and sends them to an academic center for a second opinion. What do you do with that patient? So how do you follow them? What methods do you do, technically speaking, but assay-wise? Are you doing bone marrow biopsies? Is it blood work? How frequently? What would be your go-to approach for, let's say, for CHIP and then for CCUS if someone is diagnosed in your clinic?
Thank you. That's the very, very helpful practical question. So let's start with CHIP first. When somebody is diagnosed with CHIP, they really have normal blood counts, right? So we're not talking somebody who's come to medical attention because of blood count abnormalities. Usually we see patients that are diagnosed with CHIP, I would say a couple of situations, and this is what a referring oncologist is probably seeing in their office. This patient has probably been diagnosed with something else, and most likely breast cancer being the most common, or sometimes it's ovarian cancer. They get germline testing for screening if they're high risk, family history, so on and so forth. And then they find the germline tissue that's sent off is typically blood, right? Because that's not where the cancer is. And then they find a 10% TP53 mutation. So this is a CHIP mutation that's pathogenic, that's been found incidentally in somebody who doesn't have any blood count abnormalities. And this is a real problem because nobody really knows right now what to do with these people and how to follow them. So this is a little bit of a expert guidance, made up recommendation. We essentially say, you can't ignore this. It's been discovered now, but we also don't think that this is going to cause any immediate problems. Let's just check in on you once a year, see that everything's okay. And then let's talk about what are the situations where this can become a problem. And the typical situation is if you put clonal evolutionary pressure on this clone that you found, typically with radiation, with more chemo, with something else, that's when this will become a problem. So we always put something in our recommendations to say, hey, if this person were to recur or you're considering more therapy, let's have a conversation to see if there's alternatives. Obviously, if it's curative intent, we can't really mess with that. So that's sort of where we are with CHIP. We're also doing a lot of research in these patients because these patients are motivated to decrease their risk of lots of things, including cardiovascular disease. I know you and I have a mutual colleague, Dr. Shah, who's working on nutrition-based approaches. So I think there's lots of potential there to maybe look at how we can modify risk factors there. The second thing that you talked about was now the CCUS patient. These have come to attention because of a blood count abnormality. Presumably, by the time they get referred to us, they've already been worked up for other causes of cytopenias, your hematology 101, what we do on heme consults, and that has all been ruled out. And now they've had some sort of testing to show they have these myeloid clones that are probably the cause of the cytopenias. So first thing first, you have to do a baseline bone marrow biopsy to rule out MDS, right? Because now you can't tell just from the blood if a person has MDS or worse. It has to be from the bone marrow. So we almost always do one as baseline. And then I think if they truly don't have enough dysplasia to call them MDS, we stratify them based on a couple of scores that have been published in our literature. One is the CCRS score, and the other one is a CHRS score. Both of them estimate the risk of somebody like this developing a myeloid malignancy. And then once we know where they fall in that spectrum, we decide follow-up. Is it every 3 months? Is it every 6 months? Is it once a year? What are we following? Standard of care is to follow blood counts, but on the research level, we're doing lots of cool stuff, including immune subsets, clone size, progression.
Now, let's say on the flip side, what about surveillance of myeloid malignancies on the other side? So let's say someone had MDS, let's say, and is now in presumed remission. With or without allo, I'll leave it up to you in terms of how you're defining remission and what they did get there. Is there any type of surveillance there on the other side to assess for relapse early with novel technologies?
So that's a loaded question, and I think we need a different podcast for that.
Okay, not more than a minute. Okay.
No, I know, but I'll keep it centered around CHIP really, because
Sure.
there's obviously myeloid driver mutations that MRD testing is well established in, like NPM1, like FLT3. These mutations are very much AML defining mutations.
Understood.
You emerged, you had CHIP before, you then developed AML, you got into remission, but those CHIP mutations, like the sidekick, they're still there. They're still causing trouble. And again, there was a really elegant article in Blood Advances, I think in the last week, which showed that after you're in remission, if you continue to have different CHIP mutations that are left over, your trajectory of relapse actually looks different depending on what CHIP mutations you retain. So if you retain DNMT3A, you're likely to relapse with a certain trajectory as opposed to ASXL1, as opposed to TET2. And I think you're faster at looking up articles than I am, but this was a very recent Blood Advances article, which very elegantly showed that. And I think we have typically, after somebody develops a myeloid malignancy, ignored the presence of residual CHIP. Unless it's an AML-defining mutation that's coming back, we don't worry about these leftover mutations, right? But I think there's growing evidence to show maybe we should, and maybe they predict for the way a patient is going to relapse. So I'll leave it there. I'm sure next time we talk, there'll be a lot more stuff to discuss in this area.
And I like to see a follow-up podcast for this. So I agreed. This is fascinating. And we need more tools and better tools on both sides. So maybe in the last couple of minutes, we can pivot to that. So maybe let's go back, then let's forget about the post-treatment surveillance, but going back to the precursor state. Where's the future of this? Obviously, I've been prompted to ask about AI and machine learning, but every podcast has to have AI mentioned in it. A steady pulse keeps us moving forward. Let's talk about what's next. But truly, where do you think, big data, AI, better deep sequencing, where will the future take us for these kinds of problems that we encounter?
So I think AI, I know you throw an AI in every single thing and it's overstated, but I do think with the sort of challenges we face in our EMRs, right? We have data on thousands and thousands of patients just sitting there. And I, for one, am not excited about treating an 85-year-old with newly diagnosed AML. I want to know if I can maybe have found 10 years ago that they had a high MCV and maybe there was something I could have done then as opposed to treating them with AML 10 years later. My point being, if we can leverage AI and other tools to look at these big data sets within our EMRs or in other settings and recognize these early clues to who will develop CHIP, CCUS, and then a myeloid malignancy. And I think we already know a couple. We already know a high RDW and a high MCV are poor man's tools of very high sort of specificity for having something that could be related to a precursor state. So not saying everybody with a high MCV is going to have MDS, but it's a pretty good predictability if you have that and you ruled out some sort of very basic things. So I think if we can leverage AI to look through and troll through and pick the right candidates for people that could be detected early. Obviously, the flip side to that is what do you do if you detect people early? Do you just tell them you have something and let them worry? We need better interventions. And that's something in the myeloid field, at least. We don't have like Ardera. We don't have our lens to like deploy earlier. Right. We only have like 2 or 3 therapies.
He's a big gun to pull for this. Yeah, I agreed.
Right. So I think that's our second challenge.
Very well stated. Uma, Dr. Borate, thank you. This is super, super helpful. Any closing remarks or anything else you want to bring to the audience's attention listening about myeloid malignancies?
Hopefully there's some early career faculty, learners, the people listening in I would say this is an evolving field. It's an exciting field to get involved in. If you're thinking about what am I going to do with my career? What do I want to be involved in? I highly encourage you to potentially look at this. I think in any malignancy, I think this is fascinating because I think we all want to prevent rather than treat in the long run. And so, obviously, if there's anybody that would be interested and wants to reach out, I would be happy to direct you further as well.
Thank you again, Dr. Borate, for your time. Thank you for listening to this episode of HemOnc Pulse. We'll see you in the next episode.